These folks don't know that you're the rep. Not very many people here this morning.
12. Good Kendall's just joined.
I see Ginger in there.
Morning, John and Missy. And thank you, John, for yesterday.
Mm-hmm. Is Ginger going to put her jewelry back at the gallery?
Has everybody voted? Has anybody voted?
We have.
We have. We voted by mail the day that they first came out.
All right.
As did we.
Mhm.
So how was it at the polls when you voted at the polls?
I don't.
Voted by mail.
Yeah, I
Yeah, I don't know that anybody here is
I voted-
admitted to voting in person.
I actually dropped our ballot. I dropped my ballot off yesterday morning at Huff High School and there was nobody in line, but the parking lot was starting to fill up. That was about 10 a.m.
Oh, good.
But Huff High, if anybody is going in person, I know Pam and Steve Mange voted over there and said it took about 5 minutes.
Mhm.
Nice.
I hand delivered Bob's vote to the election center downtown
Ooh,
2 weeks ago, and I plan to go to the polls either Monday, tomorrow, or Tuesday.
Yeah, get that in the mail.
Well, no, I'm going to go vote
Oh, good, good, good.
at the poll. I just have a thing about going to the polls, so I thought I'd give it a go.
It was really good at Huff, Jane.
Okay. And that's where Kerry Houston's working too, I think.
Okay. Yeah, right there off Bailey Road.
Yeah.
Yeah.
Steve, are you
Can anybody?
ready to go?
I'm ready.
A what?
It's almost 9:45, and we'll make sure that Steve has lots of time to answer questions. That's
Okay.
assuming we have lots of questions to ask of him. But thank you again for joining us and being with us and instructing us about your experiences and thoughts about how to deal with our world in this current situation. So Steve, take it away.
Okay. I think I know most everyone on the call. For those who don't know me, my wife, Phil, who's down there under Phyllis's iPhone on my screen, and I have lived in Davidson since 2000. I'm a physician. Phil is a nurse. If you go to vote at Huff High School today, Jane, she'll be there as a poll observer. So from 1 to 5. So you'll see her and say hello. We had 4 children, one of whom went to Vance High School, now Julius Chambers High School. Name was changed. The other 3 are North Mecklenburg High School graduates, and they're all scattered around the East Coast these days. I got asked to do this class largely because 12 years from about 2000, in my 2008 to 2020, I had time spent with a not-for-profit called Touch Foundation, worked primarily in Tanzania in East Africa. I spent the first 4 to 5 years in that country working in the healthcare sector, largely around health system strengthening. And then Tony last year or sometime asked me to do this class with an emphasis on my experience in Tanzania. Last week we talked about just health equity to kind of frame the discussions over the next 3 weeks with an idea that just in the back of your mind, when you see something or hear something from me, to just be asking yourself the question, is it fair that what I'm telling you, does it seem fair to you? Is essentially the equity question I'd like us to be asking ourselves over these next sessions. And today is one that is centered. I'm going to share my screen here in a second. Centered on my experiences in Tanzania. Next week, I was thinking about doing something that compared countries across the globe, but then I was kind of rethinking it a little bit. Possibly I'll move. I was going to do the last Sunday on COVID, and with mostly a focus on the disparities that are associated with some of the outcomes that we're seeing in COVID, because I think that it is an equity issue. And I think maybe I'll do that next week. And then, the Jeopardy category potpourri, I think maybe that might be the 4th week is a potpourri Sunday. I don't know if you've had one of those classes before, but maybe we'll do that on the 4th one. And just because I've had some questions accumulate, Missy asked me one last week about Medicaid expansion in North Carolina and whether there had been any demonstrated difference in health outcomes. And there are some studies early on and that weren't showing much difference from what I looked at, but a January 2020 article in the Journal of Health Affairs did surveys of 15,000 people across the South, 4 states that expanded and 7 that didn't. And of the 14 states that haven't expanded, 7 are in the South. So the South is a region of our country that's not been expanding Medicaid. And according to that survey, there was some difference in people's perception of whether their health had declined. More did over time if they were in a state that had not expanded Medicaid. Likewise to their mental health. That's one of the early studies that do show some difference, Missy, and it's in a survey form. So I don't know how hard that data is, but there is some indication that people in the Medicaid expansion states at least have a perception that they're doing a little bit better than those others. And I think Mary Thornberry pointed out, she was with us by YouTube last week, and she pointed out that one of the health inequities globally is something called brain drain. And I don't know how familiar that term is for everybody on the call, but what it amounts to is that health workers in countries that are low middle income tend to migrate to countries of high income based on better opportunities for themselves and their families after they've had their medical education. It happens in the nursing and physician sector primarily, in sort of the higher skilled categories. And it's been a global phenomenon for quite some time. And it particularly hits hard the Caribbean and sub-Saharan Africa inside countries themselves. And we experience this in the US. You have problems with health worker distribution a paucity of density of health workers in the rural areas, and people tend to gravitate to the suburbs and urban areas to live. And when health workers are free to move around, you'll find them gravitating to where they have a higher quality of life. And that's true whether it's inside a country or between countries. The problem is what to do about that inequity in terms of what kind of limitations for migration you might try to put in. And then that limits individuals' freedom to be able to move to a better place for their family. What kind of agreements countries might have between themselves not to poach from others. And that's probably the best solution, is for countries to have some form of agreement between themselves around an arrangement that doesn't end up having people permanently lost to a low-income country on the basis of their migration after they've been trained. I know in India, at least, once the quality of life there increased, a lot of the folks from that country who had moved to where they could practice at the top of their license that's one of the main reasons that at least physicians move, is they've had all this extensive training and then they go out to a healthcare setting and can't put into practice what they've learned, and they lose their skills, and they want to move to a place that's highly equipped and better able to support their what they can do. And so a lot of folks move to US, UK, New Zealand, Australia for that reason. And folks from India had begun to move back over the last decade because India had improved. It's a big thing to have to wait on for, say, Tanzania to improve socioeconomically, so people move back. So it is, as Mary pointed out, a source of inequity that you can ask yourself: is it fair that a country spends $500,000 training their healthcare workers like Jamaica, and then a large percentage of them move to higher income countries? No, it's not fair. But the bigger problem is, what do we do about it? So those are two examples of potpourri that might come up for the fourth Sunday. So feel free to send me, and I can put my email in the chat, but feel free to send me. Yeah, I haven't started sharing my screen yet. Feel free to send me questions or call me or see me on the street like Mary did. Let's. Okay. Try to get slides. This is the same slide we started with last time. And as I confessed, I used Google and Charlie Renal to try to come up with a Bible verse that had something to do with equity. And Google found this one for me. And I was just interested and curious as to whether there was a biblical reference to equity, and here was the verse that I found that did actually distinguish it from justice and righteousness. And it's what we're trying to learn a little bit about in these 4 sessions. We're going to focus today, I said, on Tanzania, but within the Tanzanian context, focus on a medical problem of maternal mortality. And this, from a Touch Foundation that I worked for, was a health system strengthening organization, which meant that we needed to tackle problems that had a systemic root cause or problem to the problem at hand. And what I mean by that is, let's take maternal mortality and compare it to malaria. And maternal mortality, the reason that women die is often because they have emergent complications during their pregnancy and delivery that contribute to their death, and they can't get to a place where they can receive proper healthcare services. And so the problem extends across the levels of care, whether that's a primary care dispensary out in the village, all the way up to a secondary or tertiary hospital that can perform cesarean sections. You have to have a solution that spans across the various levels of care to be able to address the problem of maternal mortality. Whereas with malaria, you could distribute insecticide-treated nets, and and save a lot of lives. So at one single level in public health, you can, implement a solution that makes a big difference. And the organization that I work for wanted to focus on systemic problems with a systemic solution, that if you strengthen the system, you'll save lives. And so maternal mortality was an area of focus for the work that we did in Tanzania. And this shows global statistics, not Tanzanian statistics. So every year about 300,000 women die during pregnancy, which averages to just over 800 a day. And there have been some improvements because it's part of the Sustainable Development Goals, Millennium Development Goals, to be able to reduce maternal mortality worldwide. And so there has been some progress, and we'll get to some specific statistics in some countries in just a minute. And younger women, some pregnant in their teens, experience more risk of complications than others. And that this is an area where skilled healthcare can contribute to saving lives. So it is an area where if you strengthen the healthcare delivery system itself, you'll save women's lives. Now, this slide we had last time, because we talked a little bit about what were the major categories that help contribute to whether you are healthy or not. And on the right, I just added the main factors that prevent women from receiving high quality care during their pregnancy. And you can sort of map the right side of this slide to the left and kind of say, poverty is a social problem, distance to facilities is a social problem, lack of information is probably both a social as well as an individual problem. The poor quality services are under health services, cultural beliefs and practices, really a social problem. So when you come up with a solution to deal with maternal mortality, you're really tackling this right side of the slide largely, and we'll move to this is a framework that helps understand what are the barriers to care that women experience, and why they may die in the process of delivering a child, or even earlier in their pregnancy. And so it's a public health framework and called the 3 delay model. The first one happens at home, when women and their families don't necessarily recognize they're even having a problem. Sometimes it's relatively obvious, but there are other problems in pregnancy. Say your blood pressure is rising. That's one of the problems of pregnancy, is a high blood pressure during pregnancy, and it may rise and you don't even know that it's happening, and you haven't received antenatal care, and you don't even know that it is even a problem. So there's things that can happen right there at home that slow down the person's access to getting health care. The second one is, okay, you have a problem, let me get to where some help is. And delay in getting to help is the second delay. And the third one is getting somewhere, and then once you get there, you don't get help fast enough. And that delay can be, you show up at a dispensary when you're bleeding to death and they've got nothing there to help you to stop the bleeding or to deal with your problem. And so you get to healthcare, but you get to the wrong place. That can happen in Tanzania. Or you get to a healthcare facility and they're out of supplies or medications or whatever the issue is. So in a weak health system, that third delay is fairly significant. And in a poor country with low socioeconomic status, poor education, poor transportation, you can potentially imagine in a place like Tanzania that the delays in all 3 of these categories are substantial. And it's why you'll see there's in a minute, when we look at the statistics, why so many women die in pregnancy in Tanzania. So I want to show, this is the organization that I worked for when I was in Tanzania, and I'm going to see if I can show a video. See if this works.
Most Tanzanians have limited access to basic health services. Since 2004, Touch Foundation has been working to strengthen the Tanzanian health system. Working with local hospitals and educational institutions, we train healthcare workers and address the most urgent health needs, including maternal and
Nobody
newborn
else is
health.
saying that.
Tragically, a Tanzanian woman is 80 times more likely to die during pregnancy than an American woman. Working with Vodafone Foundation, USAID PEPFAR, and Elma Foundation, mobilizing maternal health saves the lives of women and newborn babies with innovative, cost-effective solutions. With limited ambulances, women in Tanzania do not have easy access to skilled health workers in emergencies. Our ambulance taxi system helps women reach high-quality care. When a pregnant woman or newborn faces a medical emergency in the village or local health facility, they need help quickly. When a woman is in trouble, she can call a toll-free line. A dispatcher located at a hospital receives the emergency call and arranges for transport to the appropriate hospital, either in an ambulance or in a community taxi. Meanwhile, the hospital receives information about her status so they can prepare specialized life-saving care, such as a C-section for obstructed labor. Community taxi drivers are paid via M-Pesa, Vodafone's mobile money transfer system, at no cost to the patient. Thousands of patients have been transported so far, and we have reduced the number of women dying from pregnancy-related causes by 27% and saved many more newborns. Crucially, our maternal and newborn health program extends beyond transport and supports the entire health system.
Ungekuwa haupo usafiri, sijui ningefanyaje, sijui ningebebwa kwenye baiskeli, ingekuwa hakuna huduma hiyo, mimi ningetoweka duniani.
Touch Foundation's work and the work of our partners is helping people live longer and healthier lives in Tanzania. The next phase of mobilizing maternal health will focus on scaling up the emergency transport system to serve more than 90,000 pregnant women and their newborns. Your gift to mobilizing maternal health is highly leveraged with a 3-to-1 match from Vodafone Foundation. Donate today to save the lives of mothers and newborns.
So this program, during the video, is called Mobilizing Maternal Health, but it's been renamed Mama, and we implemented this program in a single district outside of Mwanza, Tanzania, where Touch Foundation was based and where I lived for the 4 to 5 years that I was in Tanzania. My job was to go and find partner hospitals out in the district to partner with the tertiary hospital that was a teaching hospital in Mwanza. And so I visited a number of different districts and district hospitals initially to deal with that problem that Mary was referencing, brain drain or distribution of physicians, because a lot of rural people would move and live in the bigger city of Mwanza and not go back home to the smaller towns and district hospitals for a lot of the same reasons doctors and nurses leave countries. The district hospitals were just understaffed and under-resourced. And this was the highest level of care that the women in the district could receive. And so, the problem that we dealt with initially was the health worker distribution, and we put a teaching program in the district hospital and sent medical students and specialists to this hospital and strengthened the hospital a bit. And then we laid on top of that this maternal health program that you just saw in this video, so that women could get to the district hospital and get the higher level of care that they needed, oftentimes a C-section or blood transfusion or something that was a higher level of care that they could get in a village dispensary, and then did all the work that was required to document that it made a difference. Then we could convince the government to do it in a region, and then eventually in the entire country, and then other countries are taking on this program. What I think that this illustrates is, I think there are three basic things that contribute to a strong health system. Equity is one of them. Sustainability is another, and just higher quality services is the third thing. It's like a three-legged stool. And part of the problem with being in development work like Touch Foundation and others is that we don't pay attention to what's sustainable. And some of that is, I live across from the CVS parking lot, so I'm going to use an analogy. It's like if I wanted to plant a garden in the CVS parking lot, I could spend a lot of money on dump trucks and bring fertilized soil in there and dump it in the parking lot and grow tomatoes for one season, but then the rain would wash the soil away, and then I'd be left with the parking lot next year, And so a lot of development work in these countries is similar to that. Spend a whole bunch of money on dump trucks and dirt, dump it in the parking lot, grow tomatoes for one season, and it's not sustainable. An example of that here is that in these hospitals, you'll see Mercedes-Benz ambulances up on cement blocks, that people have tried to deal with this problem that you see here. And they buy an ambulance for the district hospital and say, now you can get your mamas to the hospital when they need emergency transport. Well, then they don't take into account that there's no budget for fuel, that there's no car maintenance technicians to keep something up, that the Mercedes-Benz ambulances is built for city roads and can't drive on village roads. And so a lot of folks using development money do dirt in CVS parking lot kind of solutions. And so to be able to take drivers that already had a car, that they've driven on these roads before, they lived in the villages, and to be able to connect them to the pregnant women in a way that also paid them, and then have the government put that in their budget, contributed to this being a more sustainable program over time, and therefore it could be replicated elsewhere because it was affordable right at the get-go. It doesn't mean that eventually they won't have better roads and have ambulances and pre-hospital EMS systems as the socioeconomic systems in the country can support it. But in the meantime, mothers are still dying, and you need a program in place now, and something that's going to be in place not just this year, but the next, as they make that kind of evolution socioeconomically. So that was the solution that I was a part of developing and implementing in Tanzania when I was there. And I'm going to pause for a second and see, because I can't see everybody when I'm sharing my screen. So if there's anybody that has questions or comments now, I'm going to pause for a second. And if not, I will keep going. So,
Steve, excuse me.
yeah.
It's Lacey.
Hey, Lacey.
I saw in the first slide that the ages were 10 to 14. And so do they have babies at that early age? And is there birth control for these people, these mothers?
There is birth control. Accessing it is a problem, and the culture is heavily paternalistic. Women are not empowered in that culture particularly, and the healthcare decisions are often made by the quote unquote head of household, and so women and girls are not empowered in this culture to the degree that they need to be, that even if there is access to birth control, that they're allowed to use it. So you see another cause of death is somebody having 7 or 8 children, and by that time they're more subject to postpartum bleeding and that kind of thing because their uterine muscle is not as strong as it once was. And so there's that problem as well, is that in the older women, they've had so many pregnancies that they're also at higher risk. And I would attribute that a large part of that to cultural practice and a lack of women's empowerment.
Yeah. Okay.
So I mentioned earlier that there are sustainable development goals, and this is the current one in terms of maternal mortality. And I wanted to show this number because in a second I'm going to just have some comparative statistics across U.S. and Tanzania and another country, which is right here. So if you look at these numbers from 2000 to 2017, these are women that died relative to 100,000 live births. How many women, for every 100,000 live births, how many women die in pregnancy? And you see the comparisons across these three countries. And just in terms of, you see improvement in Tanzania, but it's still just, horrible in terms of the number of women that are still dying there during pregnancy, and clearly in ways, deaths that could be prevented, because you see the best case scenario over there in Finland around, that some of the deaths are going to happen, but they should be happening at a rate you see that's happening in a place like Finland. But then you see the United States and what we're looking at. And the one thing that I would point out is, and we talked about this last week, was that we're having a disturbing reduction in life expectancy in the United States. Well, the trend in the United States is that maternal mortality is increasing. It's not, it's not dramatic, but it's going in the wrong direction. So it's yet again, if you were to sort of put a thermometer somewhere in the United States, the temperature's going up. I mean, our system is sick. It is not well. And you can look at our outcomes, and we'll talk about COVID next week, but we have some problems here in the United States, whether it's life expectancy, maternal mortality, COVID mortality. And so it's no wonder that it's a focus of concern for everyone. We talked about voting earlier. When we're going out to vote, is the healthcare in our own country. But take a lower socioeconomic country in sub-Saharan Africa, and the burden there is massive, and in terms of the mortality for women during pregnancy. And I put this here. It looks complicated, but it speaks to the latter point. And this is the entire world. And I highlighted the three countries. And this compares a trend from 1990 on the left to the 2016, which is the x-axis. And so what this shows is that as a country, if you've improved maternal mortality rate over those decades, then your bubble of your country should be above that line in that graph. United States is one of the few countries that has worsened. Look at all the bubbles up there. Even Tanzania has improved. Finland's improved, and they didn't have much improvement left to make. And they're at the last bit of juice in their lemon in terms of reducing their mortality. I mean, on 6 women out of 100,000 were dying, and now it's 3. Well, that's improvement, sure, but we're not improving. I mean, that's just a problem. Certainly up here on this end of the spectrum, when you've got hundreds of women dying for every 100,000 live births, that is a huge problem as well. And that big circle right there, that gray one, is the entire world. And the maternal, the goal was to take that level and bring it down to 70, which would be down in here somewhere. And so you'd want this big circle in the sustainable development goals to head in this direction for improvement over time. But that's embarrassing. Speaking as a physician, an American physician that worked in the system for as long as I did. And then I wanted to highlight It's not exactly Missy's point about Medicaid expansion, but it is a little bit of an internal look at the United States to get an idea that, you know, we're a big country and we vary state by state in terms of thinking about this. And of course, we average what the US is and come up with the number 19 or whatever. But here you can see the poorest performing states in the union in regards to their maternal mortality. And in general, across the entire country, Black women die at a higher rate than white women, almost 3 to 4 times as higher maternal mortality. And that speaks back to you guys asking the question, is it fair that Black women die at 3 to 4 times the rate of white women when they're pregnant? I would say no, it's not fair. And then you have to dive into why that is. But, that fact is probably got an equity explanation, at least in part. But then you look at these states and see how poorly some parts of our country are performing relative to the rest of the world and relative to other states in our country. The best performing state is not on this slide. It's out in California, and their number is 4. They're performing similar to Finland in California. Georgia's performing similar to some lower socioeconomic country. And I'm not going to show this whole video, but I thought I'd show one more. Well, could you see the last one? Phil said she couldn't see it but she was looking at her phone. Did y'all see the last video?
Steve, Cecil did not see it.
Did other people see it?
We
No,
could not see it, but we could hear it.
You could hear it, but not see it.
Yes.
Right, me too.
Was that true of everybody?
Yes.
Charlie could see it.
Could not see it.
Mary could see it, but I'm on a big laptop. I don't know.
Okay. I don't know. We'll see. I don't know what to do about that since I don't know if our Zoom helpers left me. It's probably too late. You can go to the website if you want to see the video. Actually, I apologize for that. It's just touchfoundation.org and see it. It's only a 2-minute video, but I apologize. I wasn't aware that it would be a problem. And maybe this one will be too. I don't know what. I just wanted to have a quick video. This is in reference to what we were just talking about. This is a video about what it's like to have a baby in Georgia.
Deep breath. Hold it. Push like you got to push.
All right. Is it still a problem in being able to see it or?
Yes.
Yes.
Yeah.
Boy.
You may have to reshare because you're sharing currently your slideshow. You may have to reshare wherever you're playing it from. So whether it's your browser or YouTube.
Thank you, Zoom helper.
Of course.
Figure out how to do that now. Let's see. Oh no. Sorry. Right. What did that do? 1 second.
Yeah, that's working. But we can't hear it.
Deep breath. Hold it. Push like you got to push. Hold it there. Push. Go hard. Push.
Georgia ranks #1 in the country for maternal death. If you look at our census records from the last century, most women died during labor or immediately afterwards. Having a baby is serious business. Most women in Georgia, they have to travel for obstetrical access.
No labor and delivery unit, no doctors who can deliver babies.
Hey, it's Dr. Pickett. What's happening? We have a patient on the floor whose fetal heart tones are down. They're not coming back up.
The U.S. is one of only 3 countries in the world where the rate of maternal deaths is rising. Only 60% of pregnancy-related deaths are preventable.
People are feeling the pressure of either doing the work or the guilt of turning people away. That's a tough call. And eventually, the system's going to fall apart.
Let's take a look at our baby.
It's a boy.
Yeah.
Oh my God.
Right there. I'm gonna put man. My name is Dr. Donna Adams Pickett. I'm an obstetrician gynecologist who practices in Augusta, Georgia. I would describe Augusta as a mid-town. It's not Atlanta, but it's not a small little hamlet either. On an average day, I'll see 35 to 40 patients a day. When I talk to my friends in other areas that are more OB dense, most of them see roughly 25 patients a day. But the situation demands it. When we look at the statistics in Georgia, it's roughly 93 counties that do not have hospitals that have obstetrical care. So most women in Georgia, they have to travel for obstetrical access. The consequences can be fatal. How are you? Okay. So I'd like to send you over for an induction. Got some pretty impressive swelling here, though.
It's honestly been worse at the beginning of the week. These are compression sore wounds.
So what we're concerned about is something called preeclampsia. Are you familiar with that?
Yeah, it's like the high blood pressure and it can cause seizures.
That's when it becomes eclampsia. But the big thing is that it's time for us to have a baby.
Yeah.
It would be best for a patient to be able to have access to a labor and delivery unit within 30 minutes of their home. In Augusta, we are the main source for patients as far away as 2 hours in either direction. So I wasn't going to show this whole thing.
Remember handing me that one
Let
6
me-
weeks ago?
Yeah.
Figure out how to stop it now.
My name is Dr. Jeffrey Harris. I'm practicing.
Hey, Steve, I have a question when you've got a minute.
Yes.
This is Pam. So I noticed that it was a decrease, maybe like it was 2010 or 12 or something like that. So has the access to local care decreased in that time? I mean, what has caused the increase of maternal death and the decrease of availability of medical care?
I think one contributor you saw when with that map in Georgia, and it is shutting down of rural hospitals and a lack of care in those areas is probably one of the major contributors to that. It's access issues. So in Tanzania, 30 minutes to that district hospital when the women were getting there by bicycle was impossible. Some women were taking 8 hours or something to get there in the middle of labor. In Georgia, it's taking some of these women 2 hours when in an emergency when it should take 30 minutes or less.
And it used to be better, but since like 2012, it's gotten worse. So
I think it used to be better, and I don't know the statistics everywhere. I think it's across the country that rural areas are having their hospitals closed down.
Got it.
And one of the things for quality of care is that you need to do enough of a volume of business to be good at your business. And so if you're delivering just a few people a year and you've got one C-section you need to do, the people doing the C-sections don't do them enough to be good at it. So you've got that counterpoint to the other. It's not like you want a whole system with everybody being able to do C-sections when a few of them are only going to do a handful because they won't be any good at it. So you do need to have a little bit of a thought to, what's the density of population? How can I get the majority of people where they need to be in 30 minutes, where the holes are, that sort of thing. You need an overarching kind of approach to this that right now is kind of piecemeal. Our system is a combination of private, public, and, it's just one of the overall reasons that I think across the board in all of our health outcomes, we're not doing well. And I don't know, we're at 10:25 in that. Does anybody want to be able to see that video right now? I mean, you can see it on your own. I don't want to repeat it if you heard it, but the Tanzanian video, I specifically wanted to see it just because it has a lot of nice visuals that I blew it and didn't show you guys.
I do have a question. Can you hear me? It's Ginger.
Hey, Ginger, yeah.
I know in Alaska where they have, everybody's so far from the hospital and they're in villages that are only accessible by airplane, they have airplane ambulances. And if a mother is at risk, they actually fly them off of their village to Juneau or a larger city that, the last month of their pregnancy. Is there any way that airplane service could be used, bush pilots or something?
In Tanzania, the hospital that received the patients had an airstrip for a while, and then there are flying doctors in Africa that were part of a not-for-profit, and so there were airstrips, but they tended to bring in the health worker, not the patient. They weren't used as ambulances. They were used to bring a specialist to an area that otherwise wouldn't get there. And that's what these little airstrips were used for. When I was there, the airstrip wasn't active anymore. I think the road system had improved enough so that you could get the specialists out there if you needed them by road, by tarmac, to get from a tertiary hospital to a district hospital. The road system had improved so then you wouldn't bring a specialist out to a dispensary because they couldn't do the C-section that wouldn't be equipped. And everything is so dispersed that a pre-hospital system that would have an airplane close enough to where a woman needed to fly from was a problem. I don't know about in Alaska in terms of hydroplanes and all these other ways to get an airplane to a woman, but that's part of the problem in Africa is the woman would be far enough away from a piece of land that could be an airstrip that it wouldn't probably end up being a practical solution to fly a woman to where she needed to go. It's on Lake Victoria, so there are a lot of women on islands in the district that we worked in, and so boats were a part of the solution, but not planes. Yeah. And so any other questions or comments at this point? Okay. What?
Yeah, Steve, I kind of have a question.
Yeah.
So I'm still stuck and struck by your image of the CVS parking lot and putting in a whole lot of dirt and growing tomatoes for one season. That's really, that's a valuable metaphor for me. And so what does it take? I mean, this is kind of a huge question, but what does it take in a place like Tanzania to enable better sustainability?
Well, it's a long-term perspective, and unfortunately, the mentality for development is similar to the mentality for corporate investment, like annual earnings, short-term returns, the patience to deal with work that doesn't have an immediate return. People aren't willing to invest in development work that doesn't see a return on that investment for a decade. Oftentimes the folks given money for these purposes want to see an impact in a short period of time. It leads to the dirt in the parking lot approach because you get tomatoes in the season. But if you really are say, look, I know the CVS parking lot, if I take a jackhammer out there, I take cow manure and I spend years developing the fertility of that parking lot, you're not going to get tomatoes to eat, and people are dying right now. So there's a pressure to get immediate return on investment because people are dying as we speak. I think that, in our own community, there is similar sort of pressures. So we have a COVID emergency, and we have money that we need to divert to people that are in crisis in the moment. But there's ongoing resiliency issues around being able to take people on the edge in our community and have them less subject to crisis after crisis after crisis. And that's a long-term bit of work, and it takes philanthropists who understand the difference between a crisis response and a system strengthening response, and with the patience to say, I'm willing to give to something that I'm not going to see a tangible return on my gift for, a number of years. And not everyone is that patient.
Steve.
Yeah.
This is Charlie.
Hey, Charlie.
I appreciate your presentation a whole lot. When you're talking about tomatoes, it reminds me that we're talking also for healthcare about nutrition. And one of the ways that DCPC has to improve nutrition, although it's not a quick turnaround for tomatoes, is Bread for the World, which I'm so glad our staff and session and social committee have embraced, because the United States government, given functionality, can do more for feeding the something like, I can't remember the statistics, but huge numbers of children in Mecklenburg County who are food challenged. That is, basic nutrition challenged. And I think it, analogously to going to Georgia in our imagination, Georgia could be served by the same system that would help us. And so I think to that degree, policy is a local choice and a local task. And if we do things locally that are good, it will spread. That's just my instinct about how the abstraction of equity can become real in a broad, practical way.
Yeah, I've been, because I was in Tanzania and I had a bit of a global perspective for a while, and now I'm not, and trying to turn that global experience into local understanding. The Davidson in North Mecklenburg is somewhat unique in a lot of ways. I mean, we're in an area that surprisingly is barbell shaped in terms of its socioeconomic distribution, with one end of that being very highly wealthy, well-off people, and then a relative lower number of the middle class, and then a high number of extremely poor folks. And that's a fairly unusual dynamic, and I think we see a little bit of that in our town, but it's probably even more dramatic in our region. And figuring out how something we do that's Davidson centric could spill out into Cornelius and Huntersville, I think is worth significant thought. And the danger would be to be so Davidson centric that we don't realize that our neighbors, even in our adjacent towns, have a significant burden of need. So I'm Davidson biased, and so everything I think about a lot of times is Davidson centric, and I'm trying not to be a little bit. I'm trying to broaden myself, even when I think locally, into thinking the fact that Davidson's not in a silo, that it's a lot of folks that work here live elsewhere because they can't afford to live here. So, vast majority of the folks that work in our town can't afford to live in our town.
Steve, it's Missy again.
Hey, Missy.
Hey, I'm kind of stuck on thinking about the economic factors that have determined the growth of huge hospital systems, as in Charlotte with Novant and Atrium, and how that has impacted the loss of the hospitals out in the rural areas. And is there any way to take that system and help restore services in the rural district? Is there any interest in it? And what about it? Or have the economics determined that it's hard to go back? Could you talk or think a little bit about that? Or maybe somebody else has some ideas about that.
Well, yeah, somebody else might. There's a fair amount of reimbursement driven decision making around what are we going to do and will it pay for itself. And so to head into net negative territory where you're going to be providing a service that doesn't pay for itself is a tough decision, even if you're a quote unquote not-for-profit hospital. They still want the margins. And so it's a difficult prospect in an American health system to imagine investment in a place where you're not going to get a return on it. That's why you see the push for more of a public single payer kind of approach. Socialized medicine. Woo.
You're Dr. Righteousness.
Yeah. I'm just, I'm pretty sure it's going to be on my gravestone that I'm a socialist. So it'll be okay. Well,
Steve, is that not Finland's system?
Part of the reason I'm going to look a little bit more in depth into some of the European systems, but yeah, there are social democracies up there, and they have public health systems. Tanzania actually had a public health system. It was free care for significant portions of their population, and they have a socialist history. Their first president was a socialist, and so part of their issue was that it wasn't sustainable, and IMF and World Bank came in and shut down a lot of their public systems and forced some transition to private approaches. And so in Tanzania, it's just sort of weird to think, okay, Finland doing so well, socialized system. Tanzania doing so terribly, socialized system. So it's a bit of it's not a just pull one tool out of the toolbox and it's going to be the answer. I think our country's struggling with it. I think it's clearly, I don't want to see us go backwards, guys. I don't want to see us, taking steps back in the way that the system should develop. It's clearly already having health outcomes that are deteriorating. Why would we make it even worse? It just makes no sense to me. So there's a little, that's not Sunday school, is it? But it's not, doesn't seem fair to me. How's there? All right. Well, I'm going to close this in prayer again, unless there's any more questions. Okay. Hey, Father, thank you for this time to spend together, talking about what's fair, spending a little time with each other in this moment of crisis in our country. be with those who are struggling with the fact that they're in a place where they can't get what they need, and that they're scared about getting in trouble and not getting the help that they need. And this is just a normal part of life, Lord, to be pregnant, and shouldn't have to be scared when you're pregnant. Be with those of us who make decisions about what to do about this, and help us make wise ones, and help those in power also make wise decisions about what to do about these problems, and be guided by what's fair, what's loving, what's decent. In Christ's name we pray. Amen.
Thank you.
Thank you.
Thank you, Steve.
See you guys.
Thank you.
Feel free to send me questions for potpourri.
Thank you, Steve.
Thanks,
Okay.
Steve.
Thank you, Steve, and thank you, Megan. Good job on Zoom.
Bye,
Thank
everybody. Thanks.
Bye.
Good to see your faces.